Well, welcome everyone, each and all, and welcome to those of you who are in the room and who are joining online. It's my distinct pleasure to welcome you to the third seminar in our series called Public Health and Religion in Dialogue. This is an initiative that is supported by the university's Provost Office for Dialogue Innovation to have conversations and discussion on topics that are less well kind of represented on campus. And so our initiative is very much to invite the public health community to consider the contribution and the role that religion and spirituality may play in public health and community health. And I would like to just take a moment to acknowledge my colleague, Beth Resnick, who's very much a champion of this effort, and Michelle Duren, who's been very much behind the scenes coordinating the effort in bringing together the seminar for today. It's really a distinct pleasure to introduce Doug Oman. He's at UC Berkeley School of Public Health, and he leads a very distinctive project called the Stakeholder Project to integrate appropriate attention to religion and spirituality into public health. And I believe that's John Templeton Foundation funded. Professor Oman teaches a yearly course on spirituality in public health and has directed a traineeship on this topic. And one of his trainees, actually from several years ago, has come in from her day job to join us today, which shows the enduring power of kind of the professor-student relationship. He's also edited a book, Why Religion and Spirituality Matter for Public Health, Evidence, Implications, and Resources. It's published in 2018 on Springer. And if you just Google that title, Why Religion and Spirituality Matter for Public Health, you will find the entire volume. It's terrific. I've read many of its chapters. He's a recipient of the American Psychological Association's William C. Beer Award for Interdisciplinary Work. And Oman's 100-plus publications include Spirituality as a Determinant of Health, Emerging Policies, Practices, and Systems, that was published in 2024 in Health Affairs, and Mindfulness for Global Public Health, Critical Analysis and Agenda. And that's in a special issue published in 2025 in the journal Mindfulness. His website is dougoman.org. I invite you to visit it. It's full of fascinating information and a lot of his papers. And without further ado, I'm very pleased to welcome Doug. Thank you so much.
Thank you very much, Jonathan, and all of you. It's a real honor to be here, and thank you to all of you who've made this possible, and thank you to all of us for joining us online. So I have quite a bit to talk about today. So without further ado, I'll plunge in and show you an outline of what I hope to talk about today. And there are three major parts to talk about. First, I want to give you sort of an overview of the religion, spirituality, and health connections, something about the practical implications for what public health might be doing, as well as the evidence base and theory about the relevance of religion, spirituality, to health and to public health. And then talk about how that topic has been covered in schools of public health or hasn't been covered, and then how to address, well, what is sparse coverage, tends to be sparse coverage in schools of public health, at least in this country. And then at the end, hopefully about 10 minutes for summary, for questions and discussion. So that could include people online through the chat, as well as people in the room. And I think people hopefully will be monitoring questions online also. So keep that in mind. And I guess if people drop questions even early into the chat, then those we can try to take those into account. Okay, so let's plunge into this first topic, the overview of the connections. And actually, I'm going to give you a lot of information. You may feel like you've almost felt like you've received a full talk by the time we come to that. And the reason I'm doing that is because I think it's all relevant to the issue of considering, how much coverage or how little coverage should this be getting. We need to know what the field is that we're talking about. Okay, so first let's think about the the sort of practical, the connection points for what we might actually want to be doing. Well, on the one hand, there's a lot of relationships that can happen between public health professionals, public health departments, and the faith community. Partnering, it's often called, or collaboration, where maybe people are in public health departments are doing, a vaccine, partnering with a church to do vaccination campaigns in a church parking lot, that sort of thing. Anyway, there's a whole lot of work in that area. And then there's a whole other body of work on an evidence base on spiritual and religious engagement as something that can affect health outcomes, as maybe well, it turns out that there's often beneficial correlations, beneficial associations, a lot of evidence actually that some of those are causal to some degree. So that's another connection point. It's maybe a little less clear how to translate that into practice, but there are implications there too. So these are maybe the two major parts of the field that are sort of loosely tied together, but they go together. They're both part of each other's territory, so to speak. So let's go on and look in a little bit more depth about that. But in terms of partnerships, we should maybe at least look over our shoulders a little bit about the historical nature of it. Only one slide, though. That in the West and European history, that religious communities did pioneer a great deal of do I have a, let's see, do I have, I wonder if I have a mouse that could,
the other screen.
I think oh, it is. Okay. Okay. For some reason, I'm not seeing it on my monitor here. Anyway, that medieval monasteries did pioneer many hygienic facilities. You can read about it in a book published by Johns Hopkins Press, History of Public Health by George Rosen. First came out quite a while ago. I think it's probably still in print. Anyway, also early on, many of the medical centers were in centuries past were connected with religious orders. But more recently, in the United States, many denominations founded many hospitals that have played huge roles in healthcare in this country too over the years. So all of those are it's important to realize that this notion of a connection is not something new that just developed in recent decades. So what does it look like at present time? Well, as I was saying, there are two broad ways. Partnering can include things like health promotion, policy advocacy, and research. And then as a psychosocial determinant, that has a couple of subtypes. Let's look in some detail at those. Partnering, what are some of the aspects of that we should keep in mind? In terms of health promotion, I was mentioning, like vaccine or other health promotion campaigns, health education about all kinds of things, getting screened on different things. There's been a lot of work on that, many studies even published on that in American Journal of Public Health a few years back. Mark Dehaven reviewed dozens of studies. And in fact, in Annual Review of Public Health, Marcy Campbell, a few years back, and her colleagues, they did a review about church-based health promotion, which there are a number of nuances there, things like how do you adapt your education campaign for a local faith community? Often there's more broadly in terms of adaptation, you talk about difference between deep and surface structure adaptation. So there are different levels at which you can adapt and collaborate with the local religious culture, so to speak. And there's also the importance of how do you relate to the local faith community if you're collaborating with them. And sometimes public health has done a good job on that, sometimes made mistakes that it's best to develop a respectful and collaborative relationship. Other times, the pressure of, funding deadlines and that sort of thing, religious faith communities can end up feeling instrumentalized, that they're just used as a site. So that sometimes can leave bad feelings. So anyway, it's best to remember that the relationship aspect of it is important there. Okay, and there's considerable discussion in the literature about that. Policy advocacy. We can, if you look in the history of, there's a lot of faith-based activism that has been important for achieving many major public health initiatives, such as the CHIP initiative, Affordable Care Act, Obamacare. That sometimes gets forgotten when we dwell on the flashpoints and the tensions between faith communities and public health. So it's important to keep it in context by remembering there's a great deal of public health activism and coalitions, faith-based coalitions happening not too far from here at the federal level and also on many other levels too. And one source for that is just talking about faith-based activism, emphasizing some of the progressive sides that don't maybe receive as much attention as some of the other sides too. Finally, in terms of research, community-based participatory research is a very prominent perspective and important activity in public health. I imagine probably all of the students here have been hearing about it, learning about it. Of course, when it's applied to faith-based communities, then you end up getting collaboration in terms of research. Again, that would be something that would support the relational over the transactional or instrumentalizing approaches. Now, an overview of this actually that appeared it was done by a Baltimore minister, the late Reverend Melvin Tuggle, was this book published by American Public Health Association back in 2000. I'm afraid, as far as I know, it's no longer in print, but it's important to remember that American Public Health Association has supported these kinds of efforts. And in this book, he gave a lot of, I guess you could call it straight talk for both church leaders, in his case, especially African-American church leaders, and public health professionals about how to work together, how to make their relationship work together, what each group needed to remember, how to avoid mistakes, that sort of thing. Ideally, there might be an update that would maybe even broaden it out to other faith traditions. That could be a very helpful thing in this area. But it's important to see that there are precedents there too. And there's also interest on the global level. Periodically, the World Health Organization, there has been interest in spirituality. It's come and gone over the years. For a while, there was a great deal of interest about what relevant spirituality may have to primary care. The World Health Organization has also developed measures of spiritual health quality of life. Recently, all of this history was reviewed in this Oxford book by Peng Keller and colleagues. So there is a lot of recurring interest there at World Health Organization, as well as in many different countries worldwide, where partnering with faith communities can be very important. For example, one example is the Religious Health Assets Program International. That religious health assets is what they're sometimes called in Africa, where there are even huge portions of medical care in many countries are delivered through religious organizations and the national public health planners, just to keep track of what's happening in the country and know where resources need to be directed. That gets talked about as doing religious health asset mapping. And then another example is more broadly, there's work on getting things done through cross-sectoral collaboration between government and various private sectors. And then there's sort of emerging language calling this a pentahelix approach of maybe the idea is that there's a spiraling of learning how to collaborate together in various ways. And the religious sector would be one of those sectors. So here's one example from Indonesia of a study where they found that health promotion for older adults work best if embedded in local spiritual social structures. So anyway, I think this is probably very common worldwide. So, okay, so one takeaway from this section we just did is that these synergies are age-old, they're ongoing, and they're important, and I'd add they're global too. So now let's turn to this other side, sort of loosely coupled, but still very important aspect of the whole field, which is the evidence base in terms of, more from an epidemiologic perspective. And so, okay, more information coming. So, but I think this is all important background for when we figure out, how much attention should this receive. So here's a graph of the numbers of publications. Actually, this is in the psychology literature, but there's a lot of interdisciplinary. So I think something else, similar trends could be found in many different literatures. Spirituality was not a term that was used a whole lot back in the 1970s, but it's gaining in a lot of importance. The religion and spirituality, they're overlapping. There's increasing numbers of people in this country and in Europe, somewhat beyond that, talking about spiritual but not religious. But so it's important that both of these are getting attention. I don't think we should take the time now to do much to distinguish these terms. I think for most of what we're talking about, we can just talk about them together. Anyway, you can see that there's large increases over the decades in the publications, and they're often getting used together in titles. And then, so already by the year 2000, there was possible to identify more than 1,200 empirical studies of spirituality, religion, and health outcomes. And then that almost tripled by the end of the first decade in this century. And after that, people stopped counting. That maybe their estimate of about perhaps about 13,000 by a couple of years ago. A lot of this work has been done by Harold Koenig of Duke University and his colleagues. What people are still counting is reviews and meta-analyses of spirituality, religion, and some kind of health outcome. And when I was asking people about 10 years ago, even people in the field, how many reviews or meta-analyses might have been done, they were saying, this was the editor of the Psychology of Religion journal. He said, well, maybe 20. And anyway, there already by that time, 10 years ago, or 8 years ago, there had been about more than 100 systematic reviews. There seem to be a lot more now. This was in a recent chapter, a book published just this year. And then 95 meta-analyses, of which 44 are both. So if people say, well, I don't know if it's been studied, that's not correct. That there is a massive evidence base here that, and some of these studies are quite high quality with longitudinal data and that sort of thing. More attention to spirituality. There's also, most of this literature is quantitative, but there's also a good bit of qualitative literature, some qualitative metasynthesis. So both of those are important. Okay, so what does this literature show? Well, usually individuals, on the level of individuals, it's usually linked to better physical and mental health, sometimes to, less often, to poorer health. For example, if people are experiencing what are called religious or spiritual struggles, maybe inside themselves where they're conflicted about whether they believe something or not, and it's sort of a chronic thing that's affecting them, that can be a stressor and can be linked to poor health. Or if they're in a conflict with their congregation or something like that, that can also be linked to poor health. But by and large, and when you look at population measures, it averages out to very usually most dimensions are linked to better physical and mental health. And on the collective level, it tends to be a bit more mixed and complex, especially when you look at issues related to this discrimination. There can be already in the 1960s, psychologists were talking about religion can both make prejudice and unmake prejudice. That was Gordon Allport. And that sort of pattern seems to be continued, that there are favorable associations of some dimensions, but then unfavorable with others. So it's more mixed, but other results, there's associations with greater longevity on the population level even, and classic work by Durkheim, some aspects of that are continuing to be supported, lower suicide rates if there's more religiousness in the population. Anyway, but how does this happen? The scientific literature doesn't, it looks at naturalistic pathways. So one of the big naturalistic pathways is health behaviors, such as less smoking, that, most religious traditions would encourage in some way taking good care of your body, and would in some traditions, Christian tradition might talk about your body as your temple. So then they'll encourage, not to smoke because that's better for keeping your body better, that sort of thing. Another big pathway is social support, community support. And then a third, by the way, both of these, you could imagine secular substitutes, so to speak. You could imagine, Robert Putnam talked about bowling alone. You could imagine if you're bowling in a group, maybe that provides you with some social support. But there are some distinctive resources from spirituality and really distinctive methods of coping with stress. For example, a classic statement from the book of Job, the Lord gives, the Lord takes away. Blessed be the name of the Lord. If that's part of your culture, then if something bad happens, that can help you bounce back, perhaps, rather than ruminate on the bad thing that happened and get all involved in depleting your energy ruminating. That can help you move on. So anyway, that's just an example. There are many, actually, psychologists have identified many different dimensions of distinctively spiritual and religious methods of coping. So that, you might add, that's sort of an added value from spirituality and religion. There's some empirical evidence suggesting that it can add an added dimension to a coping repertoire, so to speak. So these are the pathways that have been identified. They're all naturalistic in the sense that this doesn't postulate anything necessarily supernatural, though it wouldn't conflict with that either. Okay, and then through all three of these, there tend to be positive correlations between spirituality and religion and mental health, perhaps through all three of these, or maybe through other things like encouraging people to be compassionate, so on. So those are the causal pathways. If you put them all together, you can see something like this. There are various ways they could get into the body and then translate into physical health. There's mental health right there. Of course, there are these moderators here, depending on the cultural context or the culture of the particular congregation, perhaps, that a person is involved with, might even turn some of these positive signs into negative signs. If you're a sexual minority in an unwelcoming congregation, perhaps some of these are negatives. Whereas if you're a sexual minority in a welcoming congregation, maybe most of those are positive. So it's important to remember that there are these moderators here. Now, Sandro Galea, who maybe a number of you know as a very prominent health researcher, I think he's Dean of Washington School of Public Health at present. Anyway, he has summed up this by saying religion and spirituality is a determinant of determinants. And actually, he wrote that quote in a foreword from a book that Johnathan was mentioning that I edited there. And this is what he says: it's one of the, if not the most foundational drivers of health, the determinant of determinants, sometimes invisible, but nearly always there. And these, by the way, are I think they're maybe the two most prominent book-length resources on this topic of religion and spirituality. This is one that Ellen Eidler did in 2014. She spoke at an earlier one of these events here at Hopkins on the same initiative. And this is what my book looks like that Johnathan was mentioning earlier. Okay, moving on. Now, what about causality? Sometimes things can be just correlation, but could there be causality involved? Well, there have been a few studies involving sophisticated statistical measures, something called E-values that are fairly new. Anyway, here's one study that found that there was lower depression among women, and and this was a prospective cohort study. And they used E-values to show that residual confounding was pretty unlikely. So even though they didn't do a randomized experiment, they showed it was very likely that their religious involvement helped reduce rates of depression to some degree. But overall, there's this problem that you can't randomize religion and spirituality the way, just like you couldn't toss a coin back in the 1960s and say, okay, coin came up heads, you're going to smoke for the next 10 years, we're going to see what happens to you. Tails for the other person, they won't smoke, you know. So that back in there, most of you have probably heard of the Bradford Hill perspectives, or sometimes called criteria, of trying to assess whether there's causality. In their case for tobacco, they developed these 9 perspectives. Len Simon and I, in a publication a few years back, we applied those to religion and spirituality. Actually, Jeff Levin had done that a few years earlier, but in our case, we found that by 2018 or so, that many of these were now supported with meta-analytic level evidence. Many of the Hill perspectives. Plausibility, I think we've already argued. Even some of these others may not be supported at the meta-analysis level, but they may be supported by individual studies. So there is actually a lot of reason to believe that there is at least partial causality going on here. And that's another thing in that book. Okay, moving on quickly. I guess I'm just packing you full of information here. But how much benefit? You know, is religion and spirituality, is it common or is it something rare? If it was something rare, like say hang gliding, then well, maybe hang gliding is beneficial and prolongs your life or shortens it or something. But anyway, it's not a very common thing across the population. But I'll get to that. I'm jumping ahead. This is just, okay, nationally representative sample. This doesn't address the prevalence, but it did find that being engaged, it actually makes a big difference. That on average in the US overall adult population, 7 years of longer life, which, well, sounds significant to me, and almost 14 years among African Americans. That's from a 1999 study. And not many studies are able to enroll 20,000 people. But so there hasn't been, to my knowledge, much replication of this finding here. But the overall findings of about 7 years, it's very similar to those reported in later meta-analyses. I think this is one of the meta-analyses. So this is not just some freak result here that anyway, it was nationally representative sample. So that sounds like it could be important. If there was some drug that added 14 years of life to some significant subpopulation, you'd want to know about it. Now, a lot of the research base is still primarily in the US and Europe, and primarily Judeo-Christian. So that's a drawback. But some of it, more simply, has been expanding in an international direction. And I know you can't read this table here. So the next slide shows some of the highlights in a more readable form. A lot of the health behavior associations and some of the outcome associations have been studied internationally, more in, with usually with cross-sectional designs, so not as sophisticated designs. But a lot of these findings are replicated internationally, and here's studies all over the world, every different continent. There was even some study in Antarctica, I forget what, but I don't think it shows up here. Anyway, it's from some scientists down there. So anyway, there is a lot of replication. So this doesn't appear to be some freak result just in the United States or Western Europe. Okay, now back to my religion is not hang gliding point, which is that this is from a Gallup report from just last month, and it's showing the prevalence of response to their survey question that they've been asking for 70 years, something like that, that even in 2025, almost half of US adults, 47%, were saying that religion was very important in their lives. And that was only a little bit lower than the response rate in the late 1970s, which was just over 50%. It went up a little bit in between, it's come down again. And then, but that's almost half. But then in addition, about 25% say it's fairly important. So, and that too has been holding kind of steady for a long time. What does seem to be increasing is the not very important group right there. So anyway, the point is that it's important at a population level. It's not just a rare thing. In fact, some of my students I found in recent years have grown up maybe in information, well, not quite bubbles, but information environments where they didn't quite realize that that's where most of the US population was. And somehow that seems important to know that. Worldwide, the religiously affiliated proportion of the global population is expected to increase from 84% to 87% in 2050. And that's from Pew Foundation. The issue, the phenomenon is not going away. So summary of religion, spirituality as a psychosocial determinant of health. Well, here I sort of want to keep us moving, but anyway, large evidence base, generally favorable for individuals, determinant of determinants. Maybe some takeaways from this are that there's, it compellingly shows the importance, at least that's the way it seems to me. And should this be surprising? Well, because some people are surprised. And I think maybe I've been surprised at some points. Anyway, large religion spirituality, perhaps it's surprising because it's a little discussed in public health. And there was also the now defunct 1960s secularization theory that religion would be replaced by science, that sociologists, including Peter Berger, created that theory that there was a lot of academics subscribed to it. It almost became conventional wisdom, but then it turned out not to be true by what happened in ensuing decades. And Peter Berger himself came out and said that he made a mistake. That was maybe 20, 25 years ago. But it sort of lingered. So maybe that's one reason why it could be surprising. But from a different perspective, this large health relevance should be unsurprising from a behavioral motivation perspective. A big part of what we need to do in public health is to motivate good health behaviors. And religion and spirituality commonly connects with what theologian Paul Tillich called ultimate concerns, existential concerns about life and death, or even eternal life and death, that draw out a lot of motivation in people. And if people see that something they want to do, such as maybe maintaining it, if that's experienced or viewed as aligned with their ultimate concerns, as something their tradition would want them to do or encourage them to do, or that tell them they need to do, then that could add motivation. So that you could almost think of it as religion and spirituality as a huge motivational resource, so to speak. So from that standpoint, it should be unsurprising that there could be large health connections going on. And then I mentioned there are these two overarching, the partnering and the determinant, but there's a little bit more to say. There are a few other tie-ins that we don't want to forget. In clinical care, which is public health, there are public health clinics, but maybe most of that's done through clinical professions. So in a sense, public health delegates it, but there's a lot of work done on how clinical care can be better and more effective, more culturally sensitive if it's tailored to people's spiritual and religious traditions. There's even this Oxford textbook of spirituality and healthcare that came out about a decade ago by Christina Puchalski and her colleagues. I think that's maybe also in Australia and the UK, Anglophone world. And then in psychology, it's gotten to the point of spiritually integrative psychotherapies. There are even reviews there showing that those can be more effective than secular versions. And then our colleague Jeff Levin has offered a perspective. You could think of a good bit of this as the translational epidemiology of religion, translating these findings about causality into various forms of practice. He has anyway, there are some subtypes of his that maybe complements that overarching perspective that I've said. So to give a backhanded sort of view of how you might look at this, the case I've been making is that to ignore religion spirituality is to ignore all these things: longevity bonus up to 14 years, enormous research base, motivationally taps ultimate concerns. So to give you a graphic, it's sort of like trying to, at least in the case that I've been making, it's sort of like trying to ignore an elephant in the room. Maybe you can try to do it, but well, is that the best thing to do? Okay, so I told you you might feel sort of full, that you'd gotten a full talk, but now let's maybe change the pace a little bit and think about how have we been covering this, and I think it's been somewhat sparse in the coverage, and then how do we address that if we decide it's sparser than it should be? Okay, I'm going to change pace a little bit. About a decade ago, several of my colleagues and I did some surveys of School of Public Health students. We ended up getting 980 responses across 24 different schools of public health. And thank you to all of those schools of public health who participated, and maybe even some of you listening, maybe even answered those surveys. And it turns out, I mean, one way to summarize these, that religion, spirituality, most of the students viewed them as receiving too little coverage. Well, you'll see some of the details next. And then we also found that those respondents who had received more exposure to the topic were more likely to think that religion and spirituality should be covered similarly to other well-established health factors. And by the way, the details on that are also another chapter in the book that Johnathan was mentioning. So let's get into some of the details. Well, there are 7 little graphs here. We won't take the time to go into all of them, but basically these were the types of questions that were asked. And you can, up here is the most frequent, 4+ times per year. So higher on each of these graphs is more frequent, lower is less frequent. You can see that pretty often people, like right down here, 31% of people had never heard about evidence of religious and spiritual involvement predicts established health behaviors. So that's about a third of public health. I'd never heard of that association. Anyway, I pull out a couple of highlights from this. One is, well, here's something that maybe was being covered, well, somewhat okay, but there was still 20% who had never heard about skills and reasons for public health professionals to collaborate with faith-based organizations and factors. But at least a fair number were, maybe a quarter had heard 2 to 3 times per term. So that's maybe not too bad. So maybe there's toeholds here. Yeah, that's okay. But let's look at another example here. On average, how evidence about the rates of adherence, religion, and spirituality in the US population, well, 60% had never heard that any statistic of that kind mentioned, which, anyway, yeah, I decided to have the elephant reappear about that one. Okay, but then we also asked them how much coverage is desirable. Well, we didn't phrase it quite. We said, have they received too little, about the right, or too much? Now, a small majority said too little, but maybe the most striking thing, and this is out of all those 980, maybe the most striking thing is that almost nobody said there's too much coverage. So I think there's leeway for greater inclusion, at least from the student perspective. As of 10 years ago, my sense is that things may not have changed too much since then. And then here's what I was mentioning earlier, that when you look at here's the experience that the frequency of the topic that the students had experienced per term, from never on the left to 4+ or more. So it turns out that the more frequently they'd experienced the topic, this line of ease here, the more likely they were to think that it should receive coverage equivalent, so to speak, to other major health factors. In other words, not just something totally on the margin, but something that's important. And the more they'd heard about, the less likely they were to think it should deserve minimal coverage. And then we asked them, well, what was that coverage about that you got? And so it seems, and then, yeah, we asked them how much do these various more specific subtopics, how much coverage do they merit? It seemed like there were pluralities or majorities in all cases that it merited similar coverage to other health factors. But there were some people who thought it needed minimal coverage. So I guess you can't please all the people all the time. Anyway, so there's, however you want to say it, there seems to be a basis for thinking that students would be accepting of a good degree of coverage here. We also surveyed public health leaders, and 24 responses. These were either deans or somebody who the dean nominated, and Johns Hopkins was included, though we aren't reporting individual results. And 20 out of the 24 agreed that evidence of religion, spirituality, and health should be included in public health education. So here's what that looked like, that there were a few who strongly agreed, some agreed, some slightly agreed. Anyway, and then only a few disagreed. There was one who strongly disagreed. And anyway, but you know, that's real data. People tend to use all the available categories in real data. But again, I think what that shows is that there's a basis also, at least at that time, among public health leaders, deans, and for more coverage of the topic. So a takeaway might be that there is a basis for going ahead. Okay, and also under coverage, perhaps. Okay, so let's go on and look at, let's sort of break this out the way we like to break things out in rational decision consideration. There are benefits and costs of both avoiding and addressing. So what are the benefits of avoiding? Well, less work, less chance of, I mean, when you venture into a new topic that wasn't part of your training, when you were mentored or whatever, then Well, there's always a danger you might make an embarrassing blunder. Hopefully with my book in hand, less chance of that. But Ellen's book in hand, less chance of that. Or maybe some of the publications you all are doing, less chance of that. But yeah, there's always that risk on people's mind. Now, some of us also, and this is probably non-trivial, that we may have had bad experiences ourselves. Maybe we grew up in a congregation where the leader the minister just said outrageous things, or anyway. So if we have our own frustrations, negativity, or even bad experiences, anyway, we may have emotions that we don't want to get. We need to adopt our professional demeanor. So by avoiding the topic, it's easier to navigate around whatever conflicts we may feel. But you know, how good is avoiding? Anyway, and then business as usual with gatekeepers, such as funders or administrators who themselves may not have heard. So those are some of the benefits of avoiding, but there are also costs, which would be increasing obliviousness to large proportions of US and world population. And then just generally the downsides of avoidance coping, that you're not being aware of what's going on, so you may make mistakes and be ineffective. Okay, what are the costs and benefits of addressing? Costs of addressing, more work, occasional mistakes. So a lot of this is the flip side. Though a little different than that. We need to help gatekeepers become savvy. We may need to process the feelings, but maybe we can band together with others who are also need to navigate around mixed feelings. And then the benefits. There can be ascending learning curves, better global attunement, and then skillfully align with ultimate concern motivation. So I think I've tried to put all four of these up here because I think I suspect that there will probably be people who will listen to this whole talk who may not end up agreeing with me that we should address it. And you know, all of these one can make a case for them. So I think it's important to realize all the different perspectives. In a sense, they're all stakeholders. These may be different perspectives from important stakeholders in public health, important stakeholders among our colleagues and administrators. And I've put this slide up here. Ideally, I think we probably don't have time. Oh my goodness. Oh yeah, time always goes faster than you think. So we may be getting to the chance to discuss this sooner than we think. Let's move on to the last part, how address the sparse coverage. My answers are yes, we should. Let's look at how we might address. So a starting point is to think about religion and spirituality related competencies. What competencies would be needed to address this topic? And a useful comparison point is that psychologists have been asking the question of what competencies are needed in psychology. They've been on the case, so to speak, for about 10 years. And here's a publication from American Psychologists, which is sort of like the JAMA or the AJPH for psychologists. You get it by virtue of being an APA member. They had a list of 16 proposed competencies. They've been doing research on that for maybe a decade, of doing surveys of how relevant do you think this is to your work, and what do you think your level is? Anyway, it's a useful reference point for how one might go about developing it. And so there's a question, could public health do something similar? There are abundant resources, several of which have been mentioned. There are also 7 chapters in my edited book, each profiling a public health course at these various universities. And then, but we, in this current project that I'm leading, that Johnathan was mentioning, we came up with some preliminary competencies. look kind of like this. It encompassed both partnering and determinant, but it's all preliminary. It hasn't been put through that big, the more formal systematization that the psychologists are well down the road for doing. So, but still, with such ideas in mind, we asked the overall project here, we wondered what could we do to help mainstream the topic, just because it seemed like the right thing to do. And our mission was, we formulated this way, mainstreaming of appropriate attention, because we want the attention to be appropriate, not, there'd be ways to do the attention wrong, inappropriate, no proselytization. So that was our mission. We had various stakeholders. We did 4 things here, but I'll cut to this: identify top priority action options that could potentially be doable. We ended up prioritizing 4 out of 24 action options considered. The common thread was educating. And we both pre-service and in-service education seemed to be important. We wanted to find ways to support non-expert spirituality public health faculty to easily assemble and tailor courses. So we thought of maybe a big online resource hub. Be a lot of work there, but on the other hand, it could help address things at a national level where probably not as many people as ideal feel confident expertise in this. And then also 2 aligned resources to educate, resources to support and educate gatekeepers, and then go ahead and systematize those competencies. So considerations for implementation, that would be iterative, that the understanding the competencies, advancing the training, and then developing more and more resources, all of those can sort of support each other. And it's important, I think, also to recognize that religious and relational skills are needed in many different health and human service professions. So one wonders, could we band together a common core course possibly? I don't know. I don't know what the answer to that is, maybe, but it's worth remembering that there's this larger context. Who knows, maybe undergraduate education should include religious literacy. Stanford went back to having a civics course a couple of years ago, mandatory for undergrads. Who knows, maybe dividends for social cohesion. And finally, work in stable contexts, which these days maybe is stable enough for innovation. You need, which might be state and local and maybe global. So I guess there's less time than I would like, but I think let's move to questions and discussion. And thank you for listening.
So we'll just start with questions from the room. Anyone have questions or comments? And then anyone online? I didn't see anything in the chat. So if there's any questions, yeah, please go ahead.
Thank you. So this talk was excellent. Thank you very much. You talked about, in terms of like why this might not be happening, you talked about prior individual like negative experience with religion or spirituality. I was wondering if you could talk a bit about bias, just like bias against religiosity and spirituality, just given current political context and how, at least from my personal perspective, I think there's bias in the secular sphere against people who hold religion, and how that might play in here in terms of like willingness to explain this message.
Yeah, I imagine that's the case. I mean, I think all of us, when we try to make professional judgments, you know, maybe a big input is sort of our intuitive sense based on our own social connections and reference points. And then we try to inform that through research and science and all of that. And if people start out, you know, with whatever position they're from, a certain bias, it'll almost inevitably be biased. But then if they haven't managed to, inform themselves through the scholarship and the science or conversations across the divide, as they say, then yeah, I mean, I suspect you're right. I suspect that biases could play a role, though hopefully most of those people would also be conscientious about professionally educating themselves if given the chance. Great question. Yeah.
Let me know from Janice Bowie.
Oh, Janice, wonderful.
You say religion, spirituality, and potential in the School of Public Health. So she's
yeah. Yeah. Should also mention that Janice Bowie, who used to teach here at Hopkins, now emeritus, she's been involved in a great deal of the work. She's been involved in several aspects of she's involved in this current ongoing stakeholder project and many earlier efforts too, and done good work. And if the timing had worked out a little bit differently, she would also helped. There would have been a chapter about Hopkins in the book because there used to be teaching about it.
She's giving you a wave on the screen.
Hi, Janice.
I have a hand raised. Cortland Robinson, please go ahead.
Hi, Doug.
Hi, Janice. Thank you for joining us. Thank you for all your everything.
Great. Thank you for being there. Yep. I see Court has his hand up, so I'm going to get off. Hi, Court.
Hey, Janice. Is there time for a question? I know we're a little bit over time. Just checking audio. First of all, thank you very much for this presentation. I'm Cortland Robinson in Department of International Health, Center for Humanitarian Health. And for many years, we've had a seminar on faith and humanitarian action. And we represent the, I hate to use the word major religions, the Abrahamic religions, but we do include also Buddhism, animism, and so forth. And I think the question is really, what do you do when religion becomes a point of friction and conflict? When people may have strengths drawn from their own religious identity, but they're othered by people either from a different identity or people who just simply have no particular faith of any kind except to be anti some other faith, Islamophobia, anti-Semitism, and the rest. And the work that we're trying to promote is not in any sort of stable environment at all. Indeed, it's sort of targeted toward unstable situations. But is there any, and we've been trying to promote the idea to our students that you need to, first of all, be literate. If you go into an area that is predominantly Muslim or even smaller minorities, you need to know the difference between Sunni, Shia, Sufi, and so forth. Same, Protestant versus Catholic. That matters a lot, and certainly in a place like Northern Ireland. Can you talk about ways in which this research might look at how religion, in a sense, both in a sense becomes a friction point, but also can also be a form of healing and convergence around interfaith dialogue? In context, the Ebola virus is one where proper burial of the dead was only resolved by bringing science together with faith leaders and say, you have to find a way to honor the dead, but also protect the living from the risk of contamination and infection from handling a dead body. So I'm throwing a lot of ideas out there, but appreciate the comment. I totally agree with you that we need more of this in the school, and just maybe comments and thoughts on how we might think about religion, spirituality as both a research question, a program question, in context where it's a tension point and a point of friction and overt violence, or certainly tension and disagreement. Thank you.
Yeah, great question. Thank you. Yeah, I think I don't have great answers for that, but I think that on the one hand, public health recognizes a number of social factors, including social cohesion within a society as an asset for health. And so that working upstream, I sort of went through that last slide rather quickly, of working upstream with other professions to try to promote, I think I did have the phrase religious literacy there on one of the slides, that, you know, if undergraduates received more education, that maybe as a foundational civics education, part of civics education, that might prevent some of those problems. And that's, you know, a multi-profession issue, all kinds of health and human service professions. In terms of actually going into conflict situations, that too, yeah, that's very important. I guess taking the lead there, I'm not sure who, the conflict resolution people or maybe others. Yeah, I think that would be a kind of specialty, but a lot of those same principles would apply. That try to disseminate religious literacy, so to speak, of mutual understanding. I think probably, you know, there's be a lot of overlap in multidisciplinary professions. So every profession that we can get up to speed could help maybe every other profession getting up to speed, would be my hope. I don't know if that answers all your questions, but those are some of the responses that come to mind.
Thank you. Appreciate that.
Yeah. And actually, another thing that comes to mind is that so often in religious traditions, there are multiple and even different points of tension within the tradition that emphasize different things. So there are enormous peacemaking resources within all the different traditions. So if those can be brought forward, if the professionals have enough religious literacy, so to speak, to be able to know what the corresponding positive resource is that within a tradition and can help bring that forward, then that's probably a general principle that could apply across lots of different situations, conflict and non-conflict.
Thank you. Thank you so much, Doug. Please join me in thanking Doug one more time.
Thank you all very much.
And please don't forget to hang around if you can, stay for some more conversation. And thank you to everyone who joined us online. It's really glad there's such a good crowd and showing online. Thank you so much. And thank you for the article on safe burial. Thank you so much. It's in the chat, and for anyone who's online, you can download it. I've got a copy.